Welcome, everybody. This is the Musella Foundation's Brain Tumor Webinar Series. Our first guest speaker is Dr. Eric Wong. Um, this slide introduces him. He's one of my friends and one of my favorite neuro-oncologists. Go ahead, Dr. Wong.
Well, thank you very much, Al. And thank you, everyone, for attending this webinar. I think this is very, very important during this unprecedented COVID-19 crisis. Just as an introduction, I am an associate professor of neurology at Harvard Medical School. I am a staff neuro-oncologist at Beth Israel Deaconess Medical Center in Boston. I'm also part of Dana-Farber Harvard Cancer Center. Here are my disclosures. And we are in an unprecedented crisis right now because the COVID-19 is set to induce a surge in the number of patients next week and the week following in the Northeast, as well as perhaps in other parts of the country. And under this crisis, we probably need to adjust our workflow. Now, before this crisis, our focus on treating brain tumor is on the patient. We apply all sorts of treatments such as surgery, radiation, and chemotherapy, as well as other ancillary medications that may or may not have an effect on the patient's susceptibility to infectious disease. And frequently, if a patient is infected, we would react to it. We would apply antibiotics, antiviral medications. We would call our infectious disease colleagues to help us to treat the patients. But during this crisis, we cannot be reactive. We have to be proactive, primarily because, one, we don't have a medications for the COVID-19 virus, and two, some of the medications can actually increase the patient's susceptibility to this infectious agents, in my opinion. Therefore, in order to treat the patients appropriately, we have to put the patient within this intersecting Venn diagram between our brain tumor treatment and the infectious disease complications. So what is the COVID-19 virus? I guess a lot of you have seen this picture from the CDC, Center for Disease Control. And COVID-19 is within the coronavirus family. And the reason why it is called a coronavirus is because of these spike proteins. S stands for spike, but there are also other proteins on the surface of the virus, and they are including M proteins, with M stands for membrane proteins, and envelope proteins, E proteins. Now, in order for the virus to replicate, it has to get inside the cell. Okay, so different viruses use different strategies to get into the cell. Most of the time, they attach to some cell surface protein. And for this particular virus, the protein that they are known to attach to is this receptor called angiotensin converting enzyme 2. And once the virus gets inside the cell, it would release its genetic content. And in this case, this is an RNA virus, so they would release the RNA and initiate the transcription, this program to make viral proteins. And the viral proteins are made in these two organelles within the cell. They are called the endoplasmic reticulum and the Golgi apparatus. And the free structural proteins that I mentioned about the spike protein, the membrane protein, and the envelope protein, they're all assembled within these microorganelles within the cell. And then the genetic material is packaged inside, and then the virus gets released outside the cell. And then the cells gets overwhelmed and patients develop symptoms. Well, the same strategy is used for our immune systems to detect deranged proteins, okay? So, so such deranged proteins can come from a virus or a tumor. So a tumor, because of genetic mutations, some of the proteins are altered. And when it's broken down, it may signal to the immune system that the cell is abnormal. And the way that the cell does it is by attaching these proteins to another protein called the major histocompatibility complex 1. And then this MHC class 1 protein would present the broken down fragmented protein to immune cells, and in this case, the CD8 cytotoxic T cells. If this is a foreign protein or a deranged protein, then the CD8 cytotoxic T cells would immediately kill the cell so that the cell does not turn into a tumor, or worse, turn into something that will metastasize all over the body. So this surveillance system is critically important for both viruses and tumors. There's another class of cells, they are called macrophages and monocytes, in which they actually take extracellular proteins and ingest it inside and then present it to another presentation protein called MHC class 2 protein. And when it's presented to the cell surface, it actually activates this class of cells called CD4 positive cells. They are called helper T cells. And this helper T cells would recruit other immune cells in order to mount a robust immune response against an infectious agents inside the cell or a tumor. So a lot of the immunotherapies that you are hearing in cancer centers is designed to, so when we make a cancer vaccine, we are trying to find an abnormal protein that the immune system can recognize and subsequently can mount a robust immune response to destroy the tumor cells. Now, why is this important? Because anti-cancer immunity is very similar to antivirus immunity. Now, this is a cause-specific mortality that was published in surveillance databases from the 1800s and up to the present time. And as you can see, cancer is really a recent phenomenon. And in the past 2 centuries, and also pretty much going back to the dawn of humanity, I would presume that our body and our system is evolved to deal with infectious agents, not cancer cells. It just so happens that the immune surveillance also works for cancer, and we can exploit that as a cancer oncologist. But throughout centuries, our body has been adapting to various infectious agents such as bacteria, fungi, and viruses. And as you can see here, there was a spike in mortality in 1918 that was due to the Spanish flu. And this spike, if you follow it along, is happening right now in 2020. So these cells, the CD4 and CD8 cells, can be influenced by our treatment, and they serve as a marker of patient survival, actually. So for patients with glioblastoma, for example, after they undergo radiation and temozolomide treatment simultaneously followed by adjuvant temozolomide, what we have seen is that if the patient's CD4 count is less than 200, those patients did not live as long as those patients who had a CD4 count of 200 or greater. And our team at Beth Israel Deaconess also analyzed another database. This study on the left side was done at Johns Hopkins, and we did a similar study using another clinical trial database here. And we also found that higher CD4 cells and higher CD8 cells correlates with a longer survival compared to those patients with a lower CD4 count and a lower CD8 count. Now, in certain patients with brain tumors and particularly glioblastomas, there's an intrinsic immune suppression going on. within the patient itself, within the patient population. So this was a study that was performed at Duke University, in which they took the blood sample from the patient as soon as they show up in the emergency room. That was before any surgery was done on the patient. That was before any radiation was done on the patient. And that was before any chemotherapy was applied to the patient. And as you can see, the CD4 count is lower than the control population, the normal population without the brain tumor. And in the normal population, the average is about 1,000 cells per microliters, some number, 1,000. But in the glioblastoma population, that number drops to about somewhere between 400 to 500. And in fact, about 15% of the patients had a CD4 count at 200 or less. So this is very, very similar to 2 or 3 decades ago, back in the 1990s, during the AIDS epidemic in the United States. And at that time, we were using CD4 as a surrogate marker of HIV infection, because some of the PCR tests to take a look at viral load and also the virus tests were not easily available at that time, or did not come into existence at that time. And as you can see, in the HIV negative population, this is a study that was done from a blood bank. Okay, so this is critically important because blood bank had to screen blood, screen and throw away the HIV positive blood, and they need to make sure that they don't transfuse HIV positive blood into an HIV negative patient. So what they found was that HIV negative patients had a median CD4 count of about 1,000, and 2 standard deviation away towards the lower end, it was at about 500. However, in the HIV positive population, the median is at about 500, and about half of the patients had a CD4 count lower than 500. So certain types of brain tumor patients and certain types of patients in the brain tumor population have lower CD4 count, and therefore making them particularly susceptible to infections. Now, I just want to point out that there are 3 drugs. There may be more, but I will only talk about 3 drugs that brain tumor patients commonly take, and that can particularly impair their immunity. Dexamethasone, temozolomide, and lomustine. Now, dexamethasone is an old drug, and dexamethasone came out in the early 1960s, and dexamethasone has been around for a long, long time. Okay. Now, the individual who studied a lot about dexamethasone's effects on the immune system is actually Dr. Anthony Fauci. And during his younger days, when he started out at the National Institutes of Health, and look at this paper that was published in 1976, when he first started out there, he was looking at the effect of various types of corticosteroids on the lymphocytes population within healthy individuals as well as diseased individuals. Now, I don't have to introduce Dr. Anthony Fauci. Everyone who watches the news knows that he's part of the White House coronavirus task force. And you see him every day in the news nowadays. But back in 1970s, he was studying the effect of dexamethasone. And he found 2 very, very important findings associated with dexamethasone. The first one is that dexamethasone affects the lymphocyte and monocyte counts. Okay, so he applied these 3 steroids to healthy individuals that he recruited at the National Institutes of Health, and he applied hydrocortisone, prednisone, and dexamethasone. And what you see is that the counts immediately drops and reaches a nadir at about 6 hours after administration of the medication, and it took the patient, these healthy individuals, about 24 hours to bounce back to the normal range, okay? However, these three drugs are not equivalent. There's some qualitative difference between them. Now, let me spend some time explaining the data here, okay? So for hydrocortisone, the open square means that the patient, these healthy individuals did not receive hydrocortisone, whereas the darkened square, these individuals received the hydrocortisone. And as you can see, when they count the cells, the cells count is lower. However, upon stimulation with this agent called PHA, phytohemagglutinin, you can apply increasing concentration of this stimulant and then drive these cells that were exposed to hydrocortisone and make them multiply pretty much close to the population that did not receive the drug. And this is true for hydrocortisone, and this is true for prednisone. However, there's a qualitative difference in dexamethasone. These cells, they just don't respond when you stimulate them, okay? And you can apply to the maximum concentration, and these cells are still do not multiply. So, and actually back in 2016, there's a group from Germany actually looked at 3 major databases and looked at patients with glioblastoma and asked the question, does dexamethasone influence their overall survival? And they went to Memorial Sloan Kettering Cancer Center and looked at their database and retrospectively analyzed the population of patients, and they had approximately 500 patients here. They also went into the database to look at the European Organization for Research and Treatment Against Cancer, as well as the National Cancer Institute of Canada, and they looked at the population. They had about approximately 600 patients here, and also the German Glioma Network, they had about approximately 700 patients here. And they all show the same thing. Patients who are taking no dexamethasone, they live longer compared to those who were taking dexamethasone. Now, you may argue that, well, the patients who are taking dexamethasone, they actually have bigger tumors and therefore their survival is poorer. However, when you look at their data carefully, they looked at a subpopulation who had gross total resection of the tumor, meaning that all the tumors that we can see on the MRI scan has been taken out by the surgeon. And still, you find the same thing. Patients who are not taking dexamethasone live longer compared to those taking dexamethasone. Now, you may want to ask this next question. Since the tumor is out, why are these patients on dexamethasone? Okay, so it is unclear why these patients are on this dexamethasone, although I have certain hypotheses about that. Now, here's an example of my patients in which dexamethasones clearly show that it's affecting their CD4 and CD8 counts. So this is a patient with glioblastoma. At initial diagnosis, his CD4 count was about 330, is lower than the average population. And he was placed on high doses of dexamethasone, 4 milligrams every 8 hours. And then the patient underwent maximum safe neurosurgical resection followed by radiation and temozolomide. And during radiation, I aggressively weaned the patient off the dexamethasone. But still, the CD4 counts dropped, and temozolomide probably has some effect on the CD4 counts as well. So it didn't come back to the normal range. And eventually, when the patients finished 6 cycles of temozolomide, the patient was in observation, and it took approximately a year and a half for the patients to eventually reach their premorbid CD4 counts. However, because of recurrence, the patient had to be on dexamethasone again, and the dexamethasone really lowered his CD4 count. And because of prolonged exposure of the dexamethasone, the patient's count eventually dropped to below 100. And because of that, I had to find another agent, and one of the other agents that we can use to decrease the dexamethasone usage is bevacizumab here. And slowly, his CD4 count is coming back up while I'm weaning his dexamethasone. Now, these are all retrospective data. In other words, we cannot control how much dexamethasone patients take. The only thing that we can do is go into the past medical records and review the data. This is not as solid as a prospectively obtained data. Okay, so in order to do that, we have to run a clinical trial, assigning one group of patients receiving dexamethasone and another group of patients not receiving dexamethasone, and follow them prospectively and see which group had a shorter survival. However, I can tell you that this cannot be done because we cannot give an agent that supposedly shorten the patient's survival. However, there was a study that was published in 2018 that was run by the Radiation Therapy Oncology Group that used an immunosuppressant called everolimus. And this is a bona fide anti-cancer drug. This is a bona fide anti-cancer drug, but it is also an immunosuppressant that transplant surgeons use after solid organ transplant. And as you can see here, this was applied to glioblastoma patients at initial diagnosis while they are receiving radiation and temozolomide. And as you can see, the dotted curve is below the solid curve. And this population of patients really had a decrease in progression-free survival as well as overall survival. So the evidence is pretty clear-cut that dexamethasone or any kind of immunosuppressant is bad for patients with a malignant brain tumor such as a glioblastoma. Now, when you add the infectious agents, the virus on top of that, we have to be extra cautious. Now, let me go into temozolomide. So this is the study from Johns Hopkins in which they looked at the temozolomide's effect that was given during radiation, daily temozolomide. And as you can see here, the platelet count dropped, but it only dropped about 20 to 30%. The white blood cell count, also the total white blood cell count also dropped. It dropped to about 40%. But the CD4 counts really dropped to about 60 to maybe 70%. And this is maintained during follow-up for as long as a year. And as you can see, the CD4 count, the average CD4 count here, when patients started out at baseline was about 600, and it dropped to approximately 200 for a prolonged period of time for up to a year after the radiation and daily temozolomide is done. Now, another drug that we looked at is before temozolomide came out was lomustine. And lomustine is also pretty toxic to the bone marrow. And this was a small study that was applied applied lomustine to patients with recurrent anaplastic astrocytoma. And as you can see, it can cause low lymphocyte count in over 1/3 of the population. And when you combine lomustine and temozolomide, and there was a study that came out from Europe indicating that the combination may prolong survival and may be able to control the glioblastoma tumor a lot better than temozolomide alone, but at a cost of higher rates of white blood cell count drop, and pretty much the combination you see about over 30% of the patient, over 1/3 of the patients develop a drop in white blood cell count. About 60% of the patients had a drop in platelet count. about 10% of the patients had a drop in lymphocyte count. And about 17% of the patients developed some sort of lung complications, infectious complications. So this is the take-home message. If you are young and healthy, your immune system is healthy to withstand a dose of the virus. How much a dose that you can withstand is probably varies from individual to individual. The healthier you are, the bigger the dose that you can withstand. If you are a medical professional exposed to the virus day in, day out, and you probably heard about doctors and nurses who are dying from this virus. So even if you are healthy, if you are exposed to a large enough dose of the virus can still succumb you. However, if you are elderly, like here, if your immune system is weakened, you don't need a large dose in order to succumb you. And if you are, if your immune system is weakened by dexamethasone or chemotherapy, it doesn't take a big dose of virus to succumb you. So this is my research group at Beth Israel Deaconess Medical Center. And thank you, and be careful in the next 2 weeks and also the month after. If you like my talk and if you think that this is very helpful, please donate generously.
Thanks.
Thank you.
Oh, thank you. That was very interesting. I learned a few things there. I didn't realize how important CD8 and CD4s were. The first question is there a dose of dexamethasone that is safe, like a low dose?
In our past research, we found that a dose less than 4 milligrams is probably safer if you have to be on dexamethasone. Okay, but that was before this COVID crisis. So I don't know what is the safe dose for patients during this COVID crisis. And I would, and this is what I am doing in the clinic right now. I'm checking patients' CD4 count. I'm checking patients' CD8 count to get some idea of what their immune competency is. And actually, patients who have glioblastoma after concurrent radiation and temozolomide, if their CD4 count is lower than 200, I probably would not administer any adjuvant temozolomide to them. So during this COVID-19 crisis, okay, because I don't want to increase their susceptibility to the virus.
Right. And as you said before, Avastin doesn't decrease the counts. It doesn't increase the counts either. It just gives you a break from the dex, right?
Correct. Avastin is a potent anti-angiogenesis agent, and it has a very potent effect on decreasing the cerebral edema. So this is the agent that I switch patients to.
Okay. Is there any way to increase your CD4 and CD8 counts? And would it help?
I don't know of any natural method of increasing it. You can potentially inject growth factors, but it has not been proven to, as far as I know, it has not been proven to improve antiviral immunity or anti-cancer immunity. So, in other words, just be as healthy as possible, and I think you have to ask the question. If you have to be on dexamethasone, you have to ask 3 questions, in my opinion. One is, do you really need to be on dexamethasone? You may want to ask your doctor that question. If so, what is the lowest dose that you can get by? And then the third question is whether or not there are alternatives, which I just told you. Dexamethasone is one.
Okay.
Bevacizumab is one alternative.
Right. You mentioned PHA before. That's not really used in the clinic, right?
No, it's not used in the clinic because now that is basically a cross-linker of probably cross-linking some of the co-stimulatory receptor like CD28 in order to make the cells make those lymphocytes multiply. Now we have better antibodies to do that.
Okay, and like blood transfusions wouldn't help the CD8 counts, CD4 counts.
No,
Would it? No.
no.
Okay. Um, Another question was, is there a link between IDH1 mutations and your natural CD8, 4, and 8 counts, or any other mutation?
Uh, I am not aware of any studies that looked at whether or not there's an association between IDH1 mutation and the number of CD4 or CD8 counts. That is an unknown.
Okay. Another question is, if somebody is MGMT unmethylated,
Uh-huh.
we know that there's less chance that the temozolomide works.
Mhm.
But we hear from a lot of doctors that they don't really use that to treat an individual patient, just basically it's for research purposes. However, with the COVID virus and all this stuff about CD4 and CD8, do you think it might be a time now that if you're unmethylated to try something different?
Yes, I think so. Because I before this crisis, I was one of the doctors who said that well, if the patient is young, even if they have an unmethylated MGMT, if they are not participating in a protocol or participating in a foreseeable protocol, I may consider giving them temozolomide because there was a small benefit that was in past. However, during this crisis, I think probably it is a prudent thing to do not to use temozolomide for the unmethylated population because it may increase their susceptibility to the virus.
Okay. Um, in general, before this crisis, how long did you use Temodar for? And did this crisis make that change?
Okay, so before this crisis, I only apply six cycles of adjuvant Temodar after radiation and concomitant daily temozolomide, uh, just like the Stoop study. However, during this crisis, there is a population of patients, if their CD4 count is less than 200, I would not apply any adjuvant temozolomide. I would tell the patients that I would stop and follow them on using surveillance and MRI scan and only use cytotoxic chemotherapy if their tumor returns.
What would you use instead?
When the tumor returns, well, that's a good question because we don't have solid data to stand on. Okay, so I have to. Please, I mean, this is unfortunately, this virus comes to us very fast and very furious. Okay, so there's no time for the neuro-oncology community to really think about this issue and develop guidelines and publish white papers about how to handle this scenario. Okay,
Right.
I'm giving you my 20-year experience and all of my knowledge about uh, uh, treating brain tumors and cancer immunotherapy, as well as my infectious disease knowledge. So, um, so I would be the first agent when patients develop recurrent disease. The first agent that I would go to would be bevacizumab.
Um, okay. Does Optune affect the CD8, CD4 counts?
No, uh, Optune does not affect CD4, CD8 counts, and Optune is certainly another agent that should be considered as a for recurring glioblastoma. And also, after patient finish radiation, um, Optune is indicated together with adjuvant temozolomide. But if someone has a lower CD4 count, I would probably um, not use temozolomide and just apply Optune alone.
Okay. While we're on the topic of Optune, somebody asked about using Optune during radiation. Um, there was a recent article about it, but is that able to be done right now?
Not right now because the Food and Drug Administration is not approved Optune during radiation. There is a clinical trial that is being planned. There was phase 1 data indicating that Optune applied during radiation uh, is probably safe. But right now it has not gone through a randomized phase 3 clinical trial yet.
Okay. Uh, on one of your slides, you mentioned everolimus actually decreases uh, the life expectancy of a brain tumor patient. One of our uh, attendees is using that and a checkpoint inhibitor and Optune right now, and actually doing pretty well. She's approaching her 4 years. She's been taking the everolimus for about 6 months now, but 4 years from diagnosis of a glioblastoma. Do you think that the possibly a checkpoint inhibitor could offset the negative effect of the everolimus?
That is a very, very good question. I think uh, the true answer is I don't know, but I can give you some of my opinions about that. Um,
Okay.
okay, so everolimus is bona fide immunosuppressant, but it's also an anti-cancer drug. Okay, it blocks the mTOR protein in the cell that controls proliferation. Um, um, the checkpoint inhibitor activate, can make the immune cells to multiply and be activated against uh, certain cancer cells uh, and potentially um, against viruses that are that the person has seen before. Now, this is a key issue. This the COVID-19 is a new virus in this population. Okay, so I don't think a lot of individuals has seen this virus before. So yes, you can stimulate the immune cells, but you may not be able to find a clone that is awakened by the immunotherapy to attack the COVID-19 infected cells in the body. So I have reservations about that strategy, but on the other hand, I basically have no data to base on except my opinion.
Okay. In your experience, has the virus affected clinical trial enrollment?
At my institution, we have halted all enrollment in clinical trial, all new patient enrollment in clinical trials. Okay, and that is because we are expecting a surge next week and the week after of COVID-19 patients. We don't want patients to come into the hospital and potentially get exposed. And as you know, when patients are enrolled in clinical trials, it's pretty intensive. They have to come in at a set schedule, initially maybe every week. So uh, there is potential for exposure to this virus. So as a result, my institution has made the decision to halt all new enrollment. However, patients who are already in the clinical trials, they are getting treatment continuously.
Good. Okay. Going back to that question about checkpoint inhibitors, can they actually help CD8, CD4 counts?
I would presume so. They can potentially expand it. But I think the key question is, um, would the expansion help provide and COVID-19 immunity? I personally don't think so because this is a new virus.
Right. Another question is, I think you covered this, but not exactly this way. She finished her chemotherapy 6 months ago, her Timidar. So she should basically have her CD8, CD4 counts back to where she was at the beginning by now, right?
Not necessarily,
No?
because depending on the patient, sometimes it
Oh, you
can be
said a year
prolonged.
before, right?
Sometimes it can be prolonged. I mean, sometimes it doesn't come up. In some of my patients, sometimes it takes as long as a year to a year and a half to come up.
Right.
So I would advise the patients to talk to her doctor and get a T cell subset checked. Um, and this is a readily available test that is available in all hospital laboratories, and certainly Quest Diagnostic or LabCorp has this test available. So the patients can get it checked and see what the CD4 count is like. Let me make another important point. As I show some of the slides before, particularly the experiment that was performed by Anthony Fauci back in the 1960s. Okay, the CD4 count just tells us the cell numbers. Okay, it doesn't tell us how healthy those cells are. So in order to tell how healthy those cells are, I would do a quantiferon test. Quantiferon is basically a TB test. Um, uh, before before this test came out, we had to do a skin test that we inject the TB antigen and then have the patient come back a couple of days later to measure how the size of the rods. Okay, but this test, it basically isolate the white blood cells and see how the white blood cells react. Okay, now there's a control within the quantiferon test in which we can get some measure of how robust the patient's ability to stimulate uh, or secrete the gamma interferon. Okay, so that's a surrogate test for function within the patient. Okay, so you have to separate between quantity and function. Okay?
It sounds like everybody should get these tests routinely.
Well, I do it for my patients.
Is there a problem with it? Is it covered by insurance usually?
So far, I mean, I have not received any rejection. I mean, these are relatively standardized tests that I don't think is very expensive.
Okay. Getting into the COVID-19 again,
Uh-huh.
do you feel that the hydroxychloroquine works? We're getting mixed messages on that.
Okay, so I'm not an expert on that, but from what I can gather, we don't have a lot of data on it, and as I was um, as I read, there was one small study that showed a positive effect, one small study that showed no effect. It has not undergone randomized clinical trials, so I would take that as an unknown. Okay, but hydroxychloroquine, I don't think there's a lot of side effects. But on the other hand, every drug has toxicity, so you have to speak to your physicians and go over uh, your your particular medical profile and see whether or not uh, that drug helps you or hurts you. I think that that decision has to be made between you and your oncologist.
Okay. And the last question that I have is, are you delaying brain tumor surgeries because of the outbreak?
No, because if a patient needs brain surgery, they need brain surgery. We will do everything that we can to support them to go through the surgery as safely as possible. Okay, so I will tell my surgical colleagues to wean patients steroid as quickly as possible. Um, but if patients needs brain surgery, it's usually pretty serious.
Actually, one more question.
Okay.
Uh, are there any promising treatments for GBM in the pipeline?
Um, that There are various types of treatments using various types of strategies, and the most popular one that is being investigated is various types of immune therapies as well as checkpoint inhibitors that are still going through the system, recruiting patients. So I cannot speak for individual clinical trial, but there are a number of clinical trials that may fit an individual patient. So I would encourage you, I would encourage the patient to look up clinicaltrial.gov. Another important point is that how feasible it is to participate in clinical trials. Okay, so as I said before, my institution, we shut down our enrollment of new patients, so you may need to call the institution and find out whether or not that institution is still recruiting uh, participants for the clinical trial.
Okay, we also have a service that helps people find clinical trials, and we've been going through calling the places for you to so you don't have to go through that.
Oh, that's
Um,
great. That's great.
yes. So that's it for today. Thank you very much. Our next webinar will be next week, again with Dr. Wong, but this time the topic will be Optune for brain tumors. That should be exciting, correct?
Yes, I will be back next Monday to talk about Optune, and Optune was first approved in 2011, so it is almost uh, 10 years since the first approval, and a lot of new development has entered into Optune. Okay, so stay tuned. Thank
Okay.
you very much.
Thank you, and good night, everybody.
Okay, bye bye.
Bye bye.